Good evening and welcome to tonight's Diabetes Chat. Tonight we welcome Amelia Cook to Diabetes Chat as our guest speaker. Amelia started as a nurse on a diabetes and cardiovascular ward in 1994, became a DSN, has completed her master's degree in advanced clinical practice and is now a diabetes clinical lead for the Black Country Integrated Care Board. Mel has a passion for improving patient care and making a positive impact and change. Tonight, Mel is here to talk about diabetes annual checks, also known as diabetes care processes. So welcome, Mel. Thanks for coming along and hanging out with the community tonight.
Not a problem. I'm very happy to be here.
Thank you so much. So what we're going to do is we do have some questions later on in the evening. And I know Mel has got some slides that she is going to present. And what I'm going to do is I'm going to start tweeting them out over the course as she sort of talks through each slide. So if you do want to minimize the chat, if you're listening now, you can minimize the chat and you'll be able to then see the slides on the Diabetes Chat account. And then if you're watching, listening back, you can obviously see the reference points on our account and then on our YouTube channel right now. And also when people watch back, you'll also see the slides on our YouTube channel. Okay, so Mel, over to you. I know you're going to talk about the 9 care processes and what is screened and why. So over to you. Can you kick us off of why do we screen people with diabetes? Why are people screened and what are the different types of screenings?
Yeah, so thanks, Tom. So the first slide that I've sort of put together, I've looked at the training that we sort of do for staff, really, in terms of training on the 9 care and what we expect them to do for patients with diabetes. So I'm looking at this, why do we screen patients? And I'm giving you all the sort of reasons why we look at the various aspects of the 9 care processes and what we do. But actually, fundamentally, what I've missed out is the fact that it's an individualised approach to care. So when you see a patient with diabetes, you want to know how they're getting on with their diabetes, whether they've got any struggles mentally, whether they're aware of their diagnosis, if they're newly diagnosed. And sometimes, a patient will walk in the room and I'll know that they've got something that they really want to discuss with me, and then they're not happy. So the first thing is obviously finding out what's the issues this patient might have, and it might be that they couldn't get an appointment. I know we're going to talk about that a bit later on. So I just wanted to bring it back to you guys, and you are obviously the most important thing in this process when we see you guys in clinic. And you might be seen by various people. You might see a HCA and say to the HCA, the healthcare assistant, what's my sugars like? What do you think of my urine result? And they sort of don't really have the answers. And then sometimes that creates an issue for patients. So then you need a follow-up with your results with somebody that can actually interpret your results. And that's something that you should all have access to, whether that's in secondary care, if you're under the hospital, or in primary care, where you might be seen by a HCA, then follow up with the nurse or the doctor that's got a special interest in diabetes. We do the check to look for small vessel disease. So I thought that would be a good place to start because it just gives you the top to toe. So small vessel disease, the first vessels we're looking at is the vessels at the back of the eye. And I've got some fantastic pictures of the back of eyes. If Tom wants to have those and tweet them out, I just thought it might be a little bit too much. So if you think about micro vessels, they're small vessels, and these can be affected in the eyes and in the kidneys. So these are the reasons why we have these checks, as in checking your urine, checking your kidney function, and obviously having your retinal screen, which I believe now is every 2 years if you've got stable eyes. So if you're only being invited every 2 years, then that may be the protocol in the area where you live. And I know they do that in the Black Country. We want to check your circulation. So we want to have a look at your feet. So what we're looking there is for macrovascular, big vessel changes. So we're looking for the circulation in the feet, and we're looking for the feeling in the feet. So I'm a big advocate for doing a really good foot check. So I've got competency documents and training for staff, so that when you come in to get your feet checked, we know what we're looking for and what we need to refer. So we're looking at circulation. We're looking at patients' weight, and not necessarily just to look for patients who may be struggling with their weight, but if you are underweight, then that gives me a lot of information about whether this patient might be type 1 diabetic. So you could have a patient come in who's lost a lot of weight, and they've come for their checks, and I'm thinking, this isn't usual, the diabetes has changed. We need to then review that and make sure that this patient is being managed with the correct medication and the correct diagnosis. Diagnosis is a whole other topic, isn't it? We could spend another hour on. The next thing I've written on this slide is cardiovascular risk. So we're looking at blood pressure. I've got some really good hints and tips about blood pressure, because you can check blood pressure at home and take your readings in, and you don't have to sit there and think, my blood pressure is going to be high and she's going to make me come back in. You can do your home reading. So we've got that on a slide further on. And obviously looking at heart risk. So that's things like your cholesterol, the urine I mentioned a bit earlier, and then status. Smoking status is important, because if you smoke, then you need medication to protect your heart. So you need to be on cholesterol tablets. You need to have good blood pressure as well. So that was the first slide on why we need to screen patients. Do you want me to carry on, Tom, or do you want to pause for a second?
No, that's great. And if anyone has any questions anytime, please on the panel, let us know, or anyone listening on our channels, you can hashtag diabetes chat and you can ask the question. We'll bring it up to Mel. Also, Mel, I completely forgot to mention this at the start of introducing you. Obviously, tonight is about raising awareness, and for people who are listening now or listening back on the podcast, to just let people know about all the different screening processes and what people should be getting. It's not to alarm people or worry people. It's about informing them, and then from there they can go speak to their own diabetes team, can't they? But tonight, from your capacity, you're here to like raise awareness, and already you're doing a stellar job. So thank you so much. Yeah,
it is about raising awareness of what you need to have, and yeah, that absolutely, Tom, I agree with you. So 9 care processes, so you know exactly what they all are. You've got urine ACR, that's albumin-creatinine measurement. You've got HbA1c, obviously for obvious reasons. I know time in range is more important. Before people say that to me, I agree with you. But this is the crude measurements that we do for monitoring in primary and secondary care, because we haven't got anything better really at the moment. Blood pressure, foot surveillance. You do a serum creatinine level. So that's for the blood, and eGFR, which is estimated glomerular filtration rate. Your cholesterol blood test, which we'll talk about. BMI, which is body mass index. Again, I know waist circumference is more accurate. The smoking and the retinal screening. So those are your 9 things, your 9 care processes. And we have got a template that we fill in, and there's various other bits we might ask you, like, are you planning a pregnancy if you're you're childbearing age lady? We might ask you about whether there's any other issues, and patients will bring up any issues that they have on top of the general information that we get. And we also ask patients about if they have any leg pain, etc., and if they've had any breathing issues. And some patients have got asthma and other things that can affect these questions and the answers. So moving on from what the 9 care is, then we're just going in now to the renal tests that we do. And there's a fantastic video by Kevin Fernando. And anybody who's been to any conferences or you know, like PCDS, I know Claire's been along, and DUK, which I know a lot of you go to. Kevin does do quite a bit for diabetes, and he's absolutely brilliant. And he's produced a video on looking after your kidneys, and he's saying, please take your urine test in. It's about protecting your kidneys, it's about protecting your heart, and that urine test can tell us if there's any pressure in the kidneys and if we need to think about medications for blood pressure, or looking at medications like gloflozins to reduce risk to kidneys in patients with type 2 diabetes, I must say, because those drugs are used in type 2. So what we find is that about 40% of people don't bring their urine sample in. And correct me if I'm wrong, you're not told what that urine sample means. And I know you guys on here are well adverse to your diabetes, and you're very, very, you know, involved and you know a lot. So a lot of patients out there, they'll go, well, you know, isn't it for infection? No, it's not for infection. We're checking for protein. Okay. I don't eat much protein. So patients get the wrong impression of what we're checking it for. So the video that Kevin's produced, I'm hoping that we can send across to patients so that they're aware via Accurex of why they need to bring the urine sample in to try and get patients to bring the samples when they come. The other problem we've got is if patients are going to the hospital, we might think that the hospital have done the urine and they haven't, and the hospital might think we've done it, and then you guys in the middle might know I've had a urine sample tested anywhere. So this is the problem that we can sometimes have. So the blood test, as I've said, it checks creatinine, which is the waste products that are in that you can measure via a blood level, and the estimated glomerular filtration rate, which I can't say, and that's usually above 90 when you're born, and it can drop as you get older. So we look at those tests, and your nurse should be able to discuss with you your own individual blood and urine results. The blood pressure check is something that I encourage patients to do at home, because it's always raised when you come into the surgery, and the guidance is 140/90 for general diabetes and population. But if you've got any other coexisting conditions, so you've got a bit of protein in your wee, it needs to be 130/80. So the blood pressure parameters are different if you've got any other risk factors going on. So say patients that have had angina, for instance, or, you know, they've got other issues related to their health, they might have sleep apnea or other things, the blood pressure target, or retinopathy, those patients' target is 130/80 for the blood pressure. And it does get really confusing when you look online and you see 3 or 4 different numbers for your blood pressure. One thing I wanted to really get across is the urine sample. The majority of patients have very low level protein. It's not something that we see a lot of, but when we do see it, we need to treat it. So it is more common, I can say, in, and you can look at research on this, in Afro-Caribbean patients, they're more likely to get urine protein and hypertension. It's just the way it goes. And South Asian patients are more likely to get issues with their heart and heart disease because of their cholesterol tends to be higher. So there's things that we know that we can look for and manage in certain patient groups when we're looking after you. So yeah, so urine protein, I can discuss levels in the chat if you need me to, but I've got another slide moving on.
Hello, I'm Kevin Fernando, a GP based near Edinburgh in Scotland. In this video, I'm going to talk about a simple but important test that helps monitor your kidney health and identify kidney damage, the Urinary Albumin-To-Creatinine Ratio, or uACR test. Your kidneys remove waste products, medications and extra fluid from your body by producing urine. Your kidneys are also involved in bone and blood health and controlling your blood pressure. So you can see your kidneys are very important organs in the body. In fact, about a quarter of the total blood pumped out of your heart every minute goes through your kidneys. That's more than your brain gets. The uACR test measures the amount of protein in your urine, an early sign of kidney damage. Detecting protein in your urine early can help prevent further kidney damage. Not everyone needs a uACR test. However, the uACR test is especially important for people living with diabetes, high blood pressure, heart disease, and those with a family history of kidney disease, all of whom are at increased risk of kidney damage. There are many other conditions that can also cause kidney damage, so do check with your healthcare professional, your GP, nurse or pharmacist, if you are living with a condition that needs a regular uACR test. Kidney damage itself leads to an increased risk of heart disease and strokes, so the mantra is, protect your kidneys to save your heart. Getting a uACR test is easy. It's just a simple urine test that can be done at any time of the day and then handed in to your healthcare professional. Just check with your GP practice when urine samples must be submitted by to get to the lab on time. Regular uACR tests are important to help track your kidney health, making it easier to catch potential issues such as protein in the urine, which could be a sign of kidney damage. Your healthcare professional can advise you how often you need to do a uACR test. A high uACR test means there is excess protein in your urine, which could indicate kidney issues, but often a repeat uACR test is required to confirm the result, as there are some causes of protein in the urine that are not related to kidney damage, such as vigorous exercise. If kidney damage is confirmed, don't worry. Your healthcare professional will have a plan to protect your kidneys. This might include lifestyle changes, looking at your blood pressure, certain medications that maintain kidney health, or seeing a kidney specialist in the hospital. So a call to action for all. Getting a uACR test done is very important as it monitors your kidney health and checks for early kidney damage. Remember, protect your kidneys to save your heart. I hope you found this video helpful, and thank you for listening.
Can I just ask you what you thought of that video? Did you think it was a little bit, I don't know, does it need to be a bit more patient friendly? Is it okay? What did you think?
I think personally myself, I thought it was okay.
Yeah.
I've not heard.
I thought it was okay too.
Yeah.
Yeah. So it's the sort of like, when I say basic, I don't mean too simple, but just as general information. It was like interesting. It said you could have the urine sample at any time of day.
Yes.
And things like that, which I think there's always confusion whether it should be the first wee of the day or if you could do it later.
Yeah. I mean, to be honest with you, what I would say is that if it's positive, I'd ask you for an early morning sample, because what it is when you've moved around, your muscles produce protein. So you're more likely to get a false positive. So yeah, we'd like to capture it. So that's why we say you can do it any time of the day. So if you come in, you can do it while you're there. But as I say, I'd get to retest. If it's positive, I'd get a retest off you. We have to do 2 anyway, to confirm, as you probably already know from other chats or whatever you've been to. But yeah, we need to do 2.
I think.
Go on, sorry.
I think a couple, like last year, the year before, I think they said I had a bit of protein and stuff, so they asked me to do 3 samples, I think.
Yeah.
And I think when they did that, then it came back to say, actually, no, everything's all right. So whether on that day I originally did it, something was just a bit abnormal, I guess, a bit higher than what they want it to be, whatever. But it seemed much better. So
Can I ask a question, Mel?
Yeah.
You mentioned a drug that you would give to people with type 2 if their kidneys were showing higher results than you would like, but not chronic failure or anything like that. Is there an equivalent for what you do with somebody with type 1?
Unfortunately not, and this is the bugbear about it. So SGLT2s like dapagliflozin, canagliflozin.
Oh, I didn't realise that what it was, because you said a drug name and I was just like, whoop.
Yeah, SGLT2s like have you heard of the SGLT2s?
Yes.
Yeah. So we can't use those in type 1 because they can mask DKA. So unfortunately we can't, but obviously there's 4 pillars of management for CKD. I don't want to make it too technical for everybody else that's listening, but you've got to look at your lipid therapy. You've got to look at your ACE and your ARB. So you've got things like ramipril and losartan, the different medications that you can use to bring the blood pressure down, having good HbA1c. So, ACE inhibitors are as good as SGLT2s. And when we discuss this, we always say that you need to have both. But obviously patients with type 2 diabetes, the SGLT2s put about 300 calories of glucose in the urine, so they're quite good for reducing blood pressure. They also slightly reduce the sodium, which they think is very beneficial to the heart and the kidneys. I don't know whether there will ever be a stage where they will be used in type 1. I don't know whether there's any trials going on. But at the moment, we're advised no because of that mask of DKA with the osmotic symptoms, unfortunately.
So basically it's sport for the other therapies around the kidney function rather than a drug that affects the kidney function. So you're just making sure the blood pressure is as good as it can be, the cholesterol, HbA1c, all things like that, which will take pressure off the kidney.
Exactly. Yeah. And the good thing about that I find quite satisfying is if a patient's got protein and as Tom said, you've had a couple of tests, it might go away, because sometimes you just get some protein because you just get some protein, and your sugars might have been a bit higher, you've drank a bit more water, you repeat it again and it comes down. So that's the low level, but obviously patients that get higher levels of protein, you see sort of 30 milligrams of in their protein in their urine, and it's regular, then you give these drugs and you actually see that protein reduce, and it's really satisfying because reducing the pressure within the kidney, because it works on the angiotensin-renin system, which obviously dilates the vessels directly to the kidney, not to the blood pressure like amlodipine, a calcium channel blocker. So that just basically dilates all vessels. But these drugs focus on the kidney, then you can actually reduce that pressure. And if you do that, then the kidney function will go back up. So you're looking for the eGFR to go back up or be as high as possible, but the urine protein to be as low as possible. I do a lot of trigger tools around kidney. We're doing a Care Me project at the moment where we're looking at the 3 treatment targets and then the complex patients being managed for medications to support kidney health. Like the 4 pillars. The other pillar are beta blockers that are sometimes used as well. But I'm going into specialist management now. Yeah, so we've just got to keep it simple. And yes, so unfortunately, it annoys me about the SGLT2s. I'm just hoping there'll come a time where we can use them. HbA1c. So less than 42. This is I'm talking now primary care. People that come through, have I got diabetes? No, you haven't. You've got pre-diabetes. So diagnosis of diabetes needs to be predetermined. So obviously you've got your 42 to 47, which is your pre-diabetes, and then your 48 at diagnosis. And talking about patients with type 2 diabetes, then you'd be looking at reviewing oral medication. SGLT2s now a second line to reduce cardiovascular risk. Lots of talk about adding them in first rather than metformin, adding them both together, depends where you work. Depends what the protocol is. I think anybody that's got high risk, if they're a smoker, they're struggling with their weight, I'd be adding SGLT2 quite early and aiming for an HbA1c of about 53 in a type 2. Moderate risk is classed as 64 millimoles, and high risk is those patients whose HbA1c is above 70. But this is part of the review. So when you're coming in for your review, your HbA1c is part of that. And I do know you can have a really good HbA1c but still be having hypo. So it's not a reflection of whether you're on insulin and you're doing well. It's just a reflection on that level at that point in time. So we do other things like we check injection sites now more regularly than we used to. It's part of the template, and lipohypertrophy is, I'm not even going to go into that because I know that's a whole other a whole other topic. All I know is that I'm seeing a lot more lipos now. I'm looking for them. And patients improving their diabetes because we're getting them to rotate the sites more. And it's old school basic stuff for me as a DSN, but it's something that gets forgotten if you're not reminded to be doing it every time you see a patient for their review. So blood pressure then. We talked quite a bit sort of as we've been going through about blood pressure. And I think sometimes we make too much of it. We make it more complicated than it is. So I just stuck to, now I'm lying, 3 blood pressures on here. One is nice, which says 140/90. Now, I'm not going to break any bones about it that primary care were quite happy when it went to 140/90 because that means they could tick their quality indicators a bit better because the parameters were slightly higher. I felt quite shocked that it had gone up to 140/90 because for all my diabetic career as a nurse for 30 years, it's been 140/80. So it's been a lot to get our heads around, I think, in primary care because we're used to saying to you 140/80, please. I almost think that that's where it should be. But hey ho, national guidance and all that. Home blood pressure's 135/85, and that's your average. So there's various different ones. I've just put a snapshot of the BHS blood pressure home monitoring because you can actually Google that and get a copy yourself. There's also ones that we Accurex out to you where we say to you, can you send your blood pressures in for 2 weeks? And we just get a line of your blood pressures every time you put one in to the Accurex app. It scrolls on into your notes, and it's great because then you can just see all the blood pressures. So we ask for like 14 blood pressures, best of 2 or 3 in the morning, depending on which guidance you look at, best of 2 or 3 in the evening. Average them out. You can do it yourself if you want to. So obviously you add them all together, divide them by 14 if you've done 14 readings, and give yourself your average blood pressure. Always good to do that because then you absolutely know 100% what it is. And you can always say to your healthcare professional, look, the last time I came in, you said I've got white coat syndrome and you just wrote my blood pressure down. Actually, here's my reading from home and it is a bit high and I'm a bit worried about it. So it gives you a bit more onus over your own health and actually getting the care that you want or that you need. The other thing to sort of mention as well, and one of the ladies on here said about the ARB, the GP changed her over.
Thank goodness we've got some really good GPs in general practice. I mean, I work with fantastic GPs, but they usually leave a lot of the complex stuff to me because they go, just put this patient on insulin for me. Can you just look at this patient's kidneys and things? So, you know, we work together. But the ACEs and the ARBs, they're never titrated to the maximum dose. So have a look at your blood pressure tablet and whether you're on the maximum dose. So if you do your blood pressure at home, for example, and it's like, you know, I don't know, 145 over 89 home reading, and you're thinking, oh, it's a bit high, a little bit high, and you're only on Ramipril 7.5, you might as well be on a 10 milligram. You know, you're on low sartan. I'm just trying to think of the doses. The low sartan 12.5. I'd have to double check myself now. You know, look at the maximum dose, look at the lowest dose, and see whether there is an increment for increase. And you know, and then that might be something that you want to consider. I'd rather have the max dose and have really good blood pressure, to be honest, because if I'm going to take a pill, I might as well take the dose that I need. Obviously, if you're on 5 milligrams and your blood pressure's perfect and you're happy and your urine protein's negative, then carry on. The other thing that's quite important about blood pressure is you don't know it's high. So if you're not checking it at home, the only time you'll find out is when you come to the surgery. So we're very good now. We weren't a few years ago at saying, excuse me, Mr. Smith, your blood pressure, it's come up a bit high today. Can you do me some home readings? And we're good now at doing that, rather than just saying, oh, it's a bit high because you're a bit nervous today. And bringing people back again and again and again and not diagnosing. So hypertension is a diagnosis, obviously. We don't make it lightly, you know. We have to make sure we've got these 14 readings, the average, we've diagnosed it. And then patients who've got hypertension need an ECG and medication management and follow up with repeat kidney functions 2 weeks after starting an ACE and different things. But I'm not going to go into the minutiae of that. But blood pressure is really, really important. It protects your kidneys, protects your vessels, reduces risk of reduces heart risk, as Kevin Fernando said. So moving on to foot examination. Now, I'm not going to say I love feet. But I like doing foot checks because, you know, your feet are like your soul, literally, aren't they? You can tell a lot about somebody with their when you look at their feet. You know, I can look at someone's feet and see if they've got any neuropathy changes, if their circulation's changed, if they've got any callus that which is like hard skin on the feet. And if you've got hard skin on your feet, it can crack and then you can get issues with your feet. So we can refer you on. We can get some podiatry support to just get rid of that callus. We can deal with fungal nails. We can support patients. So majority of the patients is troubleshooting. You don't see lots of patients in clinic that have got problems with their toes. We don't. We see very few patients that have problems with their toes. We see lots of patients that need nail care and things like this when we do our checks. You need a 10-gram monofilament, so it's like a little straw. You'll see that in the, I don't know whether there's any pictures in the trend book, but I've got some pictures of a monofilament. We should be tickling about 3 of your toes, the bottom of your foot, the top of your foot, checking your pulses in your feet, and documenting all that down, telling you your category. So there's either low, medium or high risk on your feet. And if we categorise it as moderate or high, we need to be telling you why. And if we categorise you as high risk feet, we should be doing a referral to the podiatry, obviously depending on what that issue is with the foot. Kidneys then. I like this picture, if you're looking, guys, of the kidney, because patients are like, I've got kidney changes. I didn't know I've got kidney changes. And it's normally patients, as they get older and they're coming in and they go, nobody's told me. And I'll say, oh, you've got a bit of protein in your wee, or your kidney function's dropped a bit. And they go, oh, well, I didn't know that. And it can as you get older. So I'll then explain to the patients why it could be a certain level at a certain age and what we do about it. So if you look at the CKD stages, it's anything that's less than 60, is classed as CKD stage 3. We don't code 1 and 2. And the reason we code 3 is because we need to manage it and monitor. So if you've got CKD stage 3, you should not be waiting 12 months for a blood test. You should be coming in, I think, at least 6 monthly. And if it's a concern, then we check it more regularly, 3 monthly, maybe even every 6 weeks, if we've got patients that are being managed with medication. So kidneys, again, it's a screen, and there's plenty of things that we can do to support good kidney health. Good sugars, get your blood pressure down, monitor it. More fluids. Sometimes patients are dehydrated. They come in, they're not drinking much at all. They're working through and it's hot and they don't have any water with them, or they're drinking tea and coffee all day, and they're in a dehydrated state, so that can drop your kidney function periodically. So if you've ever been asked to repeat it again, it's either that or the sample's collected and you've got a high potassium. So yeah, kidney function is really important to check and to know your own levels. So if you've got the NHS app, you should be able to get your blood results on that and have a look at your kidney function and see what your eGFR is. Okay, so I'm going to move on from that now, because there might be some questions around kidneys and we can always go back. Now, cholesterol. I find cholesterol quite confusing at times because there's so many different ways that you can manage cholesterol, and there's so many different sort of if you look at different guidance for cholesterol, like say if you look at Eden's guidance, which I've used here, it's quite simple, and I like that. But if you look at other guidance online, it'll say drop your non-HDL by 40%. And I'm thinking, oh God, which number's that when I'm looking at patients when they come into clinic? So, first of all, if your Q risk or your cardiovascular risk is above 10%, we're going to offer you a cholesterol tablet. And it's going to be above 10% if you're over the age of 40 and you're diabetic, usually. It's heading towards 10%, especially if you've got blood pressure as well. So these things increase your Q risk, and it takes into account age, ethnicity, etc., etc. Not very good if you're very young. You have to use Q risk 3, which is a lifetime risk, which I know you'll have heard. So we start at atorvastatin 20. I've given Tom the national guidance for lipids only because I'm sure there'll be some debate about type 1s and statins. So I'm just going to leave type 1s and statins there because I know you're going to discuss that in a little while. And Tom can bring that bit of the document up. But basically, if you've been type 1 for 10 years or you're over the age of 40 with type 1, you should be taking a statin. But I'm going to pause that because I know that's a bit of a debatable issue, isn't it, with patients and what your levels are in your blood and what you feel happy to do. If you're not reaching target, ezetimibe, apparently atorvastatin 40 and ezetimibe 10 is what the cardiovascular consultants describe as the sweet spot. So if somebody offers you ezetimibe with your atorvastatin, they're actually looking after you really well. I'm impressed with them. So the LDL, which is the low density lipoprotein, this is the stuff that can block up your coronary arteries, the stuff that you see that's like custard when you watch something on telly and go, ooh, I'm not looking at that anymore. That needs to be less than 1.8, and I'm getting really good at this now. So I look at that. What is your LDL, sir? That's 3. It needs to be 1.8. I'm upping your statin, or I'm starting your statin, or let's talk about it. Then if it's not achieved with the statin and the ezetimibe, then we can go to bempedoic acid. Again, I've got to be careful because I don't want to overload you with things that you might not really need to know about, but that's the next step. And then there's an injectable called inclisiran, which can be used for patients who've got quite stubbornly high cholesterol. And cholesterol comes as part of the package, unfortunately. It's part of metabolic syndrome. Certainly with type 2, it comes, you get hyperglycemia, hypertension, and high cholesterol, and it's all part of the same metabolic process as insulin is involved in the synthesis of your cholesterol, so you end up with a high cholesterol. So, good cholesterol is your high density lipoproteins, or your HDL. And I'm very proud to say my HDL is 1.4 because I go to the gym, but my total cholesterol is still not where I want it to be. So you want a HDL of above 1.1, I think it is. You correct me, guys, on here if I'm wrong, 1.1 or 1.2. Anyway, that's where you want your HDL to be. And your ratio of good to bad cholesterol needs to be 3.5 or less. So that's your good and your bad cholesterol. So I look at cholesterol quite a lot now, because if your cholesterol's good, then that reduces every risk. If your cholesterol's good. And that's what I think. If you're on a cholesterol tablet and it reduces your risk, that's going to be beneficial all the way around for everything: your kidneys, your heart, your eyes. So I am a big believer in that. I know some people don't like cholesterol medication. They don't believe that it works or that they should use it. I do have patients like that, and we do have to decline or use ezetimibe. Patients may not want them, and we have to be accepting of that, because people are in charge of their own health. It's not our job to tell patients what their beliefs and what they might want to do. It might be different to what we think. So statins we can discuss a little bit more if we need to. BMI, I'm not going to go over BMI too much, because, you've seen a lot on the news now about, BMIs above 40. People are going to get these weight loss injections for weight management. That's coming through at the moment. We're using them with type 2 diabetes, and quite rightly so, because there's only two medications that reduce cardiovascular disease in type 2 diabetes for diabetes, and one is the SGLT2s and one is the GLP-1s. So it's about reducing cardiovascular risk. So that's why we use those drugs. If somebody's BMI is between 18 and 24 and they come through the doors with an HbA1c of 100, I'm thinking, they got type 1. Doesn't matter what age they are, have they got LADA. So again, with this annual review, sometimes we pick these patients up, oh, so-and-so's just come in, can you review them, Mel? They've just had their annual review, and I look and I think, oh my goodness, that patient needs to come down and get a blood keto meter. So there's things that trigger management plans for patients, and I do appreciate when you diagnosed with diabetes, you probably don't think about all the people that are coming behind you that are being newly diagnosed with diabetes, and in fact it's becoming more common. I think, I don't know statistically, latent autoimmune diabetes seems to be or LADA seems to be more common. I don't know what the statistical data is. So with BMI, it just gives me a picture. It just tells me whether this patient is insulin deficient or whether they're insulin resistant. And so, albeit a crude value, it's good for us to give us that information about patients, and indeed to have something to support the management, which medications we're going to use. So obviously, when you're talking about that, you're talking about what's your blood pressure as well, what's your weight, is it coming down? So your BMI might be 35, but it's better than it was, and it was 40 before, and you've done really, really well. So you've got to look at the patterns with weight, and be mindful when we talk to patients about that, because there's different areas of care. So you've got patients that may want lifestyle, but you've got some patients that actually might want to consider surgery, or or need counselling or support. So you've just got to make sure that you discuss these things with patients and make sure that they get the care that they need. And the last area, which is always a bone of contention, is smoking. Smoking is a lot less common now than it used to be when I was 22. People used to smoke on films and stuff now, and then, didn't they? And now people don't, and they might vape. I think vapes have taken over. But stopping smoking will prolong your life whether you've got diabetes or not. But smoking and diabetes together is not great for your cardiovascular system or your circulation to your feet and your eyes and things. So I'm a big advocate, and we always offer smoking cessation advice. Chemists do it now, so you don't even have to go through your GP. You can just have a look on this link if you live locally, or pop into your chemist and they'll gladly talk to you about smoking. So, retinal screening. I've just put a list of codes because patients, grades, sorry, not codes. Patients will say, well, what does R1 mean? What does that mean? You know, so I've put the grades of retinal grades there. Most patients with diabetes will get some background retinopathy, especially if you've had diabetes for a long time. So background retinopathy or R1, I can still use medications for, I can still use Mounjaro for, and it's quite common to see R1. So if you've got R1, if you've got some retinopathy, don't worry, because that's usual. But obviously retinal screening is really important, and it's got to be done with the drops in, not just the one at the opticians where they check your vision. This is the one where you have the drops and you can't, you have to put your sunglasses on and you can't drive. So that's the one that's your real eye test. And we get lots of patients actually come through that have been for an eye check, because I think they do some photographs, don't they, for general eye health at the back of your eye, and they can tell if you've got a risk of diabetes. So they'll send patients to us because their retinal screen shows that they might have some diabetes or some changes in the back of the eye that they see with diabetes. So they refer patients into us for screening. So yeah, so eyes are extremely important. And
thank you so much, Mel. That was a lot of information, but a lot of fantastic things, and hopefully people take away little snippets and they can listen back or watch it on YouTube, all the slides transitioning, or the threads now on Twitter, and I've posted all that you've been saying and the links to all the website resources, including Diabetes UK, Eden, Trend, and also the link to the type 1 guidance for statins as well. So, there's a lot of information there, and hopefully people listening back or whatever, it's about raising information awareness, and hopefully you take away a few little things, and please go speak to your own diabetes team for other guidance and other support.